Good afternoon and welcome to our webinar this afternoon on the top 10 critical success factors to manage your community health needs assessment, implementation, and evaluation process. I'm Debbie Thompson, President of Strategy Solutions, and I'm delighted to have with me Dr. Bob Motley from Lehigh Valley Health Network, who's going to be our co-presenter today. Our agenda. We have a pretty action-packed agenda and a lot of information to share with you. Our agenda today includes talking about what we consider to be the top 10 critical success factors to managing your implementation and evaluation process. We're also going to be introducing a concept of some key roles and responsibilities of process managers that we found in our separate work in sort of different spheres of influence, that these roles and responsibilities actually help make the process better and easier to institutionalize. And we're going to give Dr. Motley an opportunity to share some of his experience working in the Lehigh Valley Health Network, integrating their needs assessments with their other strategic goals and managing the process, and hopefully share a little bit of information with you and allow you to dialogue a little bit and maybe share some information with each other about some strategies that you found have worked in your organization. We're also going to share a copy of the slide deck and any materials that we talk about over the course of the webinar. A little bit about me. I am a recovering hospital planner. Please don't hold that against me. I've been working in healthcare now almost 30 years. It dates me when I think about it. We've worked with different hospitals and health systems all over the country, working on community health needs assessment, strategic planning, program development, evaluation, and a whole variety of other things. I've also had the opportunity to work in a number of other sectors because of our work helping to create healthy communities. A little bit about my company, Strategy Solutions. I actually started it from my work, which I affectionately called as the CEO's Rent-A-Planner. We were heavily involved back in the 90s in community health improvement activities in Northwest Pennsylvania, and I learned early on that the hospitals alone were never going to solve the community health equation, that if we were going to create healthier communities, we were going to get private sector wealth creators to work with social services and communities and government in an integrated way and create what are now called collective impact projects that actually help to improve the health status of the community. And I started Strategy Solutions to be a kind of a rent-a-resource to community-based organizations that didn't have the resources that our health system was able to have in terms of research and planning. And we've created a planning and evaluation process that works answering these 5 basic questions. Where are we now? Where do we want to be? How are we going to get there? Who's going to do what? And then sets up an evaluation process in terms of how are we doing. And we're a little atypical for many consultants in that we have a capacity building approach where we actually teach people how to set up and implement new systems through what I call a do, teach, coach model, where we'll actually help people put those processes into place and build the capacity in their organization to institutionalize the various functions that we might be talking about. And with that, I'm going to turn it over to Dr. Motley to introduce himself and talk a little bit about life in the Lehigh Valley Health Network.
Hello, everybody, and welcome. If you are not connected to chat, I'd like to invite you to do that now and maybe use that to introduce yourself, where you're from, and maybe something you're hoping to get out of today's webinar. We're situated in Northeast Pennsylvania. We're the 3rd largest city. Allentown is the 3rd largest city in the Commonwealth of Pennsylvania, behind Philadelphia and Pittsburgh. And Lehigh Valley Health Network began at the turn of the 20th century as a small community hospital and has grown into a major tertiary care center that straddles the New York, Philadelphia, and Hershey markets, if you will, from a healthcare standpoint. I have a lot of background in community-based primary care. and did that for 20 years before coming to Lehigh Valley Health Network, where I've been able to pursue my interest in learning more about communities, the health of populations, and social determinants of health as they impact health. When you see that as a clinician, it's a really powerful thing. And you know, as a value-based organization that's trying to achieve the triple aim, we're really hard at work on trying to now address not just clinical excellence, but looking at engaged and help them address the social barriers and their psychological barriers to getting and staying healthy. So I just would like to get a little feedback from maybe some of the folks who are on the call. As we move forward this, I think, you know, the community health needs assessment is understood by most. It's really an IRS, you know, regulated government mandate, and certainly in our area for the first round of the community health needs assessment, it was looked upon that way as sort of a, oh boy, the IRS is looking for info, don't tell them much. And so getting engagement and really bringing the CHNA, as we call it, some people call it China, has been challenging in terms of getting the leaders of many community hospitals and larger health networks fully bought into how this could match up with you know, other strategic goals that the organization may have. For us, because of the necessity to measure impact, we're leveraging other resources we have for measurement and the infrastructure we have for both data and for project management. So as we are, quote, planting a new garden, we're using the CHNA to help influence sort of the cultural thinking within our health network and trying to marry it up to both the population health and even the financial goals for our organization. As many of you may have experienced, there's no right or wrong way to do this. You got to start somewhere and you use the assets you have, but I'm hopeful that as we share today, and you can share your experiences, that you may learn one or two things you can do to either make your own CHNA more effective or to help members of your organizations to kind of connect the dots to see how this can be a very worthwhile exercise. So comments, feedback, questions? Okay, well, please feel free to use the chat, and I'm going to throw it back to Debbie to help walk us through.
Okay, what we've been able to find in our work is that there are 10 steps. It's kind of a 10-step process. While you're developing and implementing your CHNA strategies, there's 10 steps to establishing an evaluation structure. Here they are. They were actually outlined in the notice that we sent out to you about today's webinar. And I'm going to stop for a second and ask you all, are there any of these that you're more interested in than others that you might like us to spend a little bit more time focusing on or talking about as we go through this? Anyone want to venture an item or two that you'd like to, that you might be a little bit more interested in than others?
Christian Healthcare Center, we would say 6 or 7.
Okay. Convening the team and monitoring team function and performance. Okay, good. Anyone else?
I'm with CHI Health, and I would add the 8, 9, and 10, really around that data evaluation and reporting pieces.
Okay, great. Anyone else? Did I mention this was a speak now or forever hold your peace moment? No, I'm kidding, really. If there's anyone else that wants to jump in and...
Hi, it's Melissa from Lehigh Valley Hospital Hazleton, and I agree. I think the data collection and the outcomes reporting is most important to us.
Okay, great. All right then. So here's the big question. How does it all really fit together? Before we jump into some of the content, I have a polling question for you. If you can, you should have a little box on the side of your screen that allows you to answer this. What level of support do you feel you have from senior management of your health system or your health department to help you really implement to support the CHNA? Do you feel you have outstanding support? Click on that button. If you feel you have solid support, click on that button. If you have good support but it could be better, you can go ahead and click on that button, or you can feel free to say, because this is anonymous, I wish I had more support. Okay, here's our responses. Some with outstanding support, some with solid. Someone said good support but could be better. And some said I wish I had more support. I think that's very similar to what we're seeing. Depends on the organization, and some places it's better than others. So what's step number one? Step number one is to help connect the dots. And here is where the most opportunity is to help build more support with your leadership team and align your needs assessment with the value-based strategies of your health system. Most hospital systems have some type of initiative related to population health, but it isn't always connected to the needs assessment goals and tactics. And we encourage our clients to really think about how what their needs assessment says really fits in with their patient engagement activities, how it fits into quality with their readmissions and post-acute continuum of care strategies, and really use the process of developing the implementation plan to really connect them together and talk about how they relate to one another, because that is not a natural process in most health systems that we've found. We also encourage folks to set a goal to automate the outcomes and impact indicators to support population health, because what we found is that hospitals are tracking and reporting data for either quality or compliance purposes that is also the same data that you could be tracking to look at, are you making a difference in the health of a population? But again, the dots aren't connected. We also encourage folks to include IT-related tactical objectives and investments to measure the outcomes and impact actually in your implementation strategy. Most people's implementation strategies are about the programs that you're doing. Are you doing a wellness program or a diabetes program? We actually encourage folks to think about, if you have to set up a measurement system or you have to put some IT resources into actually tracking your outcomes, that becomes one of the strategies of your implementation plan, so you actually put resources to that. The other thing that is helpful is to think about the difference between the letter of the law and the spirit of the law. Many organizations where there's not really outstanding support of this effort are sometimes looking at the CHNA or the China implementation from the compliance focus only. I'm doing this because the IRS says I have to. But really, if you think about it, the needs assessment process is not just an unfunded mandate. It really is a tool to help move organizations toward population-based health planning. And here's a slide that I borrowed from the American Hospital Association. This was first published, the blue and the pink boxes on this slide was first published by the American Hospital Association back in 2011, talking about how the healthcare industry is going from a volume-based first curve to a value-based second curve, where we're looking at, going from fee-for-service more into bundled payments or quality impacts reimbursement. And just last year, in June of 2015, the AHA put a third set of boxes, the green ones on this slide, related to the second curve of population health, where there's a recognition that over the next few years, and actually within the planning horizon of this particular needs assessment series, is we're going to be seeing CMS, or the Centers for Medicare and Medicaid Services, move more reimbursement to value-based reimbursement. I was talking to some folks not too long ago from California, where in the San Diego area, the payers actually have a risk pool where those health plans that are, and the hospital systems that are performing higher on the HCAHPS, that are doing better quality, that are achieving health outcomes, are actually getting a higher level reimbursement in a kind of a value-based reimbursement strategy. And what you'll see on here is the two items circled in red at the bottom of the green boxes, that these are critical success factors toward preparing for population health, including creating a seamless, integrated, comprehensive healthcare information technology that allows you to support risk stratification. I had one manager in a health system not too long ago say, you know, all of this population health stuff is about us thinking about doing the same set of interventions, but thinking about it a little bit differently with the different populations that we serve, whether it's, you know, persons that don't have insurance, or people that are in our ACO, our Accountable Care Organization, or our Medicare population. We have to be really thinking about what strategies do we do with that population to help improve their health or manage their chronic diseases better. And it's really about mature community partnerships to collaborate on risk-based solutions. And this slide is put in here to help stimulate some thinking around the fact that the needs assessment process should be both the driver and the evaluator of the effectiveness of the hospital or health system's planning or population health improvement efforts. And this also applies to health departments. We should be looking at the needs. We have operational needs. We also have the community needs. That really should be driving our priority needs and issues, our goal setting. And then every year at the end of the year, we should be evaluating, did our strategies actually help us improve care, improve health, or lower cost? That's what population health is really all about. So how do we really think about this in terms of preparing the implementation plan itself? First of all, you should be thinking about who you're going to partner with and why. A lot of hospitals, I've seen a lot of health departments and hospitals really think about what's our strategy going to be? What are our programs and services going to be? And what are we, you know, how are we going to implement it? And really part of that question should not be just what are we going to do, but it also should be who are we going to partner with and why. And determine at the board and leadership levels what your roles and relationships are with health departments, established community partnerships, safety net organizations, post-acute continuum members like skilled nursing facilities or home care agencies, or other community providers that might be involved in particular efforts. You also need to think about how do you align those resources. Do you have a foundation? Many health systems have a foundation. Many communities have community foundations that help direct resources to improving health initiatives in the community. So you want to think about strategically directing those foundation and endowment investments to support high-leverage infrastructure and impact investments where you can, and align your grant-making policies and procedures to support that strategy. You also then want to prioritize and identify your list of focus areas. Most people know how to do this. You know, you come out of your needs assessment with a list. You put them in order based on some criteria. Most people do that. You want to think about what kind of criteria you want to focus those resources on, and not necessarily responding to every request. including what do we want to be known for as a community or a health system, and appropriately communicate that selection process and carefully manage the relationships, especially if you're not going to do certain things based on your selected priorities. You also want to think about the board reporting structure. We see lots of hospitals and health systems and health departments not really think about, well, who are we reporting all of this to? It's an activity out there, but it's not really connected to the fabric of our strategy. You want to identify your board committee or your organizational oversight body, whether that's a committee or the board. You want to report your progress to the board at least annually, even though it's every 3 years that you have to put some progress in your needs assessment. You should think about ensuring that a status report is created and attached to your 990 Schedule H, because then you're demonstrating that ongoing process. It's also helpful if you actually assemble an implementation team. This actually makes it easier. We've seen in many hospitals and health systems that there's just one person's responsible for the needs assessment, or you have somebody who's the head of community wellness. It's really good to assemble a team. And the team acts as a forum to develop and monitor tactical goal achievement, help to collaborate to leverage resources. We worked with health systems that 4 or 5 different departments are all doing diabetes programs, and they're not talking to each other. And they're measuring different things, and they're not really looking at how they leverage resources. And that way it will help to allow you to measure progress and the outcomes and impact of those strategies if you have a team that's thinking about it. Who should you involve in a team? Include the population health leadership, service line leaders responsible for the clinical programs related to those high priorities.
Hey, Debbie, this is
Yes.
Bob. I was wondering if we could just pause here for a second to get some feedback from our participants in terms of who may be right now an army of one, or how many on the call feel like they want or need additional resources, and if they could have them, if we could wave the magic wand, what would be the resources they would want more of? We have a shy group today.
We do.
So is there anybody who's largely running this with maybe just 1 or 2 people assisting? That's common enough in some of our smaller community hospital settings.
Yes, we are at Christian Healthcare Center, running it with just a handful of us.
So could you say just a little bit more in terms of what you have and maybe what would be the next step in terms of the resources you'd like to have?
Well, I think we certainly have access to the resources that we need. It's 2 of us primarily leading it. We're a small mental health hospital, and we have access. Obviously, the board and executive team is very supportive. We'll eventually involve IS will be involved, and our docs are well involved, and we have some good partnerships with other hospitals and the community at large. So I think we're in good shape.
Yeah, one of the participants wrote in the chat feature, I have 1 person to assist with 8 hospitals in 3 counties. That's a tall order.
Yeah, do you want to say a little bit more in terms of where your current challenges are in terms of getting that done? Because we're all experiencing these challenges. I think we just have to have somebody fess up and say, yeah, you know what, there's parts of this that are going great and other parts that are where we're really kind of struggling.
Since we began operating under the Beaumont Health name. Biggest challenges with leadership support and dollars. And
That's absolutely true. And, you know, one of the things that we've found, and this is why we talk about, you know, clarifying staff support roles, as this is a way of really sort of creating a better division of labor within a hospital or health system to look at, you know, sort of spreading the responsibility for all of this. I was telling Bob earlier today when we were talking that I have a client in a 250-bed hospital system where all 4 of these roles, and most of the work belongs to one person. She does it very, very well, but it's difficult. It's really hard to do that. And as we've been clarifying the roles, the leader, champion, coordinator, data collector, and information informatics specialist, it's really easier if you start to unpack it to try to get people to incorporate that as part of their jobs. And it's also easier if you talk about the potential, and this is, you know, part of the conversation about getting support from senior leadership. Identify who fills the roles. Don't just ask for volunteers, but look at who are the right people to have these roles in a health system related to population health improvement, and build those accountabilities into the position expectations, because it's not just about being a volunteer. So one of the key roles is the leader or the champion. And the absence of this role sometimes makes it feel like you don't have enough senior leadership support, or you don't have the right resources behind what you're doing. And what we've found is there's really 2 aspects to the leadership. There's the clinical leadership piece, which is could be a physician, often is a physician. Sometimes it's the person that's responsible for population health. In other cases, it's a key service line leader who really is leading this, you know, sort of embracing overall health and wellness. And then there's the person who is the who does the public relations and outreach pieces of it. That's often someone who's in the marketing department or involved in marketing or public relations. And it can be the same. I said it can be the same person if you can talk them into it. And it can be separated if it's easier to co-lead for people to take different roles. But it's good to build these expectations into someone's job description. This is a key element, and I'm guessing that many of you who are on the call are people who are the CHNA coordinators. The responsibility is to facilitate the process in the calendar, making sure that the milestones happen, the activities happen every 3 years, provide technical assistance to program directors for the implementation strategies, and follow up with assigned parties to make sure that things are completed on time, or my favorite role, the terrier on the pant leg. One role that isn't often explicitly called out as a separate role is that of the data collector or the tracker, the person who acts as the central repository to collect outcomes and impact data from program managers. Most people in the early days of this are keeping track of outcomes and impact information on Excel spreadsheets or even manually. And you want to have a place where all the data gets reported, to develop a process to format and track it, provide technical assistance on how to collect the data. What we found from working with various different hospitals and health systems is that there are people in the organization that are good at collecting data. They're good at sort of putting it together and making it look pretty. And they can work with that coordinator to prepare reports and to work with an informatics staff to automate indicators and report formats when and where possible. And because of that, we're encouraging hospitals and health systems and health departments to actually designate someone in their IT world or their informatics world to be somebody that's responsible to help the CHNA implementation process, and to provide guidance regarding the development of patient tracking systems that could support chronic disease management, mechanisms to connect population health improvement efforts, and to provide education on how to electronically track things. And I'll give you an example. Many hospitals are doing outreach activities for breast cancer, for example, and they're doing clinical breast exam screenings, giving out vouchers to low-income people that might be funded by the Susan B. Komen Foundation to get mammograms. And those health fair activities that do those screening efforts, they sort of exist on their own in the wellness department or in some outreach activity. And a good example is, and you track the number of people that come, right? That's an output. An outcome would be to look at, of the number of people who were screened, how many actually scheduled a mammogram. Having a laptop available to actually do scheduling at an outreach activity actually allows you to collect outcomes right then. We've helped work with health systems to equip those nurses that go out and do those clinical breast exams with not only a laptop that allows them to schedule a mammogram for someone, it allows them to put the information into the registration process so that now we can track these people if they have an adverse test and are being diagnosed with, let's say they're diagnosed with stage 2 cancer, then they can be referred for follow-up, and now we can track them over time to look at what happened with them so we can see the outcomes and the impact of our efforts. And the Informatics Specialist, for example, was able to put 2 new fields in the data in the electronic medical record system to be able to track the screening activities, so now it becomes part of the medical record with the nurse who does the screening who has a laptop. And then the Informatics Specialist can provide technical assistance to automate these measurement systems through the electronic medical records and other systems. And what I found in working with various hospitals is that these Informatics Specialists exist in most health systems, but they're tasked with getting new systems online. They're not necessarily aware of what's happening programmatically, but their expertise can be very valuable. And I had a couple of folks that I met not too long ago could say, yep, all of those things can be automated in our new medical record tracking system, and we'll be able to write queries and reports in pretty short order after that comes online. So it changes the process so you can actually automate the reporting of your indicators and are not necessarily stuck with trying to create an Excel spreadsheet or doing things on a tick sheet. So once you get your team identified, you pull them together and ask them to identify the goals and the implementation strategies by asking these questions. What goals fit with our business strategies and what do we want to accomplish? How do we continue the past program? What evidence-based programs or approaches might be more effective? And then we ensure that all strategies and programs have identified outcomes and impact indicators and a process to measure them. And if for any of you who are interested in very specifics around, how do I identify outcomes and impact measures, our website actually has we have some recorded webinars that are specifically on the measurement process themselves and how to pick indicators. We're not getting into a whole lot of detail here in this particular webinar. We're more talking about the roles of the implementation process overall. So how would it work? The implementation team guides the development and monitoring of the goals. The teams start to meet quarterly to try to pull the information together and say, are we making progress? The program directors actually implement the plan. The staff identify outcomes indicators with the technical assistance provided by Informatics. The program staff tries to do a quarterly report. What we found in a lot of places is you've got to just start doing it and see what data you have and what you don't have and start to fill in the gaps. And then the coordinator convenes quarterly team meetings to evaluate progress and summarize the information and write it down. What we found over time is that many places are actually doing evaluation, but it's informal, it's anecdotal. We look at how, we say, is this working or is it not working, and are we going to continue it or not? We just don't formalize it very well. And then you monitor the team function and performance. You meet at least quarterly to ensure that your strategies and programs are actually being implemented. You check in with each other to ensure that the tracking and reporting systems are developed and implemented, and that the program managers can actually report the data. And that's one of the places where I think things fall down. Some places, some people can track data, some can't. And then at the end of the year, evaluate the process and say, will this work? Are we going to continue it? And this is the big deal. Document the discussion. What we see in many places is the discussion happens, it just doesn't get documented. So we encourage you to document it. And then you want to monitor the team function and performance. Oversee the development of an annual evaluation summary. Create a document. We have some examples of what those documents might look like. If you're interested in a copy of an example, send me a note in the chat feature and we'll include that as part of our information back out to you. You want to capture key processes and develop an operations manual with a calendar of activities to ensure things are done. We've also encouraged people to actually create a policy and a procedure for this. What we found is that a lot of hospitals don't have, many hospitals don't even have a community benefit policy in place, which they should.
Strategy Solutions people.
Did someone have a comment? Question?
I don't think everybody's on mute.
Oh, I don't think so. So we recommend creating an operations manual so that you document what the processes are and what the expectations are, and actually develop a policy so that the expectations of participation in these activities, again, become part of what's required of managers and not just what one or two people are required to do because, okay, Mary Smith, you're the CHNA coordinator or the China coordinator. It's your job to see that this all happens. You really need to, part of getting the buy-in is getting leadership to recognize that these are functions that need to be embedded in the fabric of the organization, not just done by one or two people once every couple of years. So then you can start to collect and review the data itself. Here's an example of this is a goal and an objective out of a hospital's implementation strategy where the goal was to reduce the incidence and prevalence of chronic diseases. The objective, what you could see here, was to increase employee engagement. And here's the metrics: number of people completing screenings, number of participants achieving goal status, number of pounds lost in a weight challenge. So here was the status report. And basically, the folks that were running the program said, okay, this is how many we had. We had 530 employees. We had 2 employee weight loss challenges, and here's how many pounds were lost. The employees in on-site fitness activities, well, when this status report was done in July, the numbers weren't available yet, so we put that in there as numbers weren't available. And how many total discounted dollars were. They had a living lean menu in their cafeteria, in their employee cafeteria. So they were looking at, that was actually a measurement of how healthy people were eating inside of their organization. So they put the numbers together and just write a status report. This doesn't have to be complicated. It's just a matter of going through the exercise of saying, Here's what we have. Here's the data. Here's another example related to decreasing late-stage breast cancer. The number of participants in health fairs, the number of people receiving a screening or scheduled for mammograms, the number of people diagnosed with cancer stages. And this particular hospital is actually looking at decreasing the number and percentage of people that were diagnosed at various stages, and how much, the people walking in fundraising walks, dollars raised, and what they're actually enhancing this coming year to include what those dollars are actually being used for in terms of funding support programs for cancer patients who have barriers to access. So that's what they're using the dollars for, that this is going to be enhanced. Part of their evaluation was to say, well, maybe we ought to look at the impact of those dollars we're raising and what they're being used for. So how do we actually conduct an evaluation process? Here's just a simple timeline. Again, this doesn't have to be complicated, but throughout the next fiscal year, you implement your programs. You establish a process to collect the data. What we recommend is the month after the fiscal year ends is you sit down and compile all the data, look at it, schedule a meeting, distribute the data to stakeholders, see if you want to get input on it. The second month after the fiscal year end, you gather feedback and input from those stakeholders. The third month after the fiscal year ends, you convene the committee, bring people together in a room and look at all the data together and ask the question, what does this tell us about how well our strategies are working? Are they working? Do we want to continue them? Do we want to move forward? And then by the fourth month, you actually want to create a summary document that will be an attachment to your 990 Schedule H regarding your activities, outcomes, and impact. And we encourage folks to create that summary document not only as the attachment for the 990 Schedule H, but as a document that you can also publish on your website about here's the progress that we're making over the past year. And then it's a matter of sharing your story with leaders and potential supporters. And with that, I'm going to turn it over to Dr. Motley to talk about the Lehigh Valley experience.
Thanks, Debbie. Before we jump into that, since there was a high interest in these last 4 steps, I'd love to just learn from the group because we are still actually establishing our infrastructure, having to go and negotiate for the assets of our data tracker and getting the cooperation of our IT folks and setting up a schedule, which we hope to codify for pulling together the outputs, coordinating them and getting them fed up to our tax folks for the 990. So interestingly, in our organization, it's actually our finance people who prepare the 990 reports, although the narrative is pulled from several corners of our network. But I'm interested in, for those who said that this was a priority area, maybe describing a little bit about your own milieu. And what at this point are you still negotiating for? Or what parts of this presentation that Debbie just finished were kind of aha moments? Feel free to use the chat box if you're not if you're muted on audio. And Debbie, I'm hoping that the mute is off.
It is. Except for the person that still has us on hold.
The other hospital in the area. Rest assured.
Yeah, somebody still has their hold music on.
All right, so either everybody's in great shape and what I'm about to share may not be all that helpful, or we just may have a shy group.
Here, I'll take a stab at it. It's Elizabeth Rubach from the Bergen County Department of Health Services. We are coordinating the 5 hospitals plus the small psychiatric hospital in our county in New Jersey. And what I've observed, because we're not under the mandate for the Affordable Care Act, but we are public health involvement, which is called for. So what I've kind of picked up from the hospitals is that it's not always, it's something they have to do to meet the IRS regulations and to maintain the not-for-profit status, but it's not necessarily that the hospitals are enthusiastic about doing. So it's hard to get the support that's needed. Now, I don't know if that's the experience of the people listening on this call, and I don't know if every single hospital in our area would agree, but that's what I've picked up just in working with the different groups that I've been involved with.
Other thoughts? Elizabeth, could you share with us a little bit who your counterparts are at the hospitals? Are these folks from the marketing department? Are they folks from the legal department?
I believe a lot of them are from planning departments, and then some are marketing, some are community health folks. My gut feeling is that there's still a hope, there's a hope among hospitals that this is going to go away. So, it's not, like, it hasn't totally been assumed or digested as part of normal hospital, operating behavior. So I think that would take a little longer in the process for it to become something and to really fully dedicate resources to it. But we seem to struggle. You can ask Debbie, in figuring out things that we can work on as a group, that I'm not a hospital, but for the hospitals to work on together that public health can also be involved in, and where we'd be able to access data that we are willing to share and evaluate. Because our group is looking to work on something that they can do, community benefit across the county, because that is the interpretation of one of the requirements, that the hospitals work together.
I think that's a great approach, and it's great. It's interesting that that's sort of coming from outside the organizations, from sort of a neutral party, someone who really has a public health perspective.
Yeah, but I will tell you, the problem is that the hospitals are understandably competitive, so it isn't like it isn't something that comes natural to the players involved. It doesn't come naturally to them. They're competitive. They have their market shares they want to protect, and so it's been a bit of an effort.
Anybody want to build on that, or maybe express a differing view?
This is Kathy from Christian Healthcare Center. It is novel to hospitals that have been in more of a competitive situation, right? But I think that one thing that the CHNA has done is encouraged us to look at what are the commonalities of issues that are very important needs in the community, and how might we rally around those. One, for example, being mental health. So from our experience, even in the previous one, we had a great partnership with Valley, Bergen Regional, which didn't participate in the, doesn't have to participate in the CHNA, another a county hospital here. We were able to forge good relationships. So I think, in part, the glass is half full in the sense that this gives us a rubric, or almost gives us an imperative to form those relationships, and I think we've been doing fairly well with that.
I agree. I am inclined to agree that finding the common ground, even in markets where there are competitors, it is really among the vulnerable. We've coined the term a lose less strategy. So for our vulnerable populations, they are the folks who are either having trouble getting access and maybe seeking care in an emergency center or in care settings that are actually very expensive, or for lack of covering a social need. If we use a lot of Maslow's hierarchy of needs to really help frame that somebody can't work on their diabetes or their asthma if they're worried about where their next meal is coming from or if they don't have housing. And so, as we've been framing this within our community, we also did a collaborative countywide, actually 2 countywide community health needs assessment. We have gotten a little bit of traction with our competitor organizations, but nobody has engaged to where we have formed a collaborative organization to work on them. Everybody's sort of retrenched to, well, I have to work on my plan and you have to work on your plan. But it's nice to know that we could talk about folks who have mental illness together and maybe explore some common resources within our community. So it is baby steps right now. Okay, other comments? With our remaining time, and Deb, if you'd be kind enough to go to the next slide. As I came into this space of having to own this process in an organization that really did not have a deep familiarity with it, I knew I needed to align forces, and in fact I joke with people, I felt like I needed to speak 3 or 4 languages. The language of the clinicians, we're a very clinically oriented network, and so for them it's about patient outcomes from the clinical perspective. But every clinician knows that they've got a handful of patients that are having a hard time making their connections, and they really understand that that's really about human needs and solving social problems. So adapting that language for the clinicians. From an operations perspective, it's really about limited resources. So when you're talking to your ops folks who have budgets that they have to do and their task list is too long, is to frame this that this could actually help them with their work down the road in terms of if you can tie it to other projects or other goals that they have. And so I took more of an appreciative inquiry approach to our operational leaders to say, what is it that you struggle most with, or what are the areas of your responsibility, particularly if I knew that they had access to coordinator resources or data tracking resources. And I would try to really just align what we're trying to do with the CHNA with what they're trying to do with their population health mandate, or in terms of trying to achieve more efficiency. And then finally, among our finance folks, they're the ones faced, and our legal folks, they're the ones faced with the regulatory responsibility, and it's not in their wheelhouse. They like to count numbers, they like to plan budgets. And so when you can say, hey, if you just give me a little of your help, I can make this easy for you, and you'll actually have a 990 that looks pretty nice, and it'll keep the IRS off your back. And so they've been very grateful for that. So when I step back and I say, well, what's really happening here? We're being asked to lead change at an organizational level that really kind of doesn't have a deep understanding about why they need to do this and how it fits. And if you're going to lead change like that, you have to create both a need and some urgency, which you'll see on the Lewins force field model there in terms of sort of diagnosing the problem, but then getting the organization to, if you will, unfreeze so that they can move to a different place and space that would be more supportive of this work. So by creating a need and then defining a direction, and if we could also take a look that as beyond that, it's really about mobilizing that commitment and then getting the resources that you need. That would be part of the moving phase where the intervention is. And I think that's where a lot of us are right now. And then as we can move to the evaluation piece of it, learning how to measure and adapt and take some learning away from that, how do we match that up with what we're trying to do with our population health strategies of going from volume to value. So we go to the next slide. If that were the big picture, I think what you'll see here is a lot of stuff that you recognize, and all these arrows would almost give you a headache. But the drivers, as we go from volume to value, many of them are valid. We've got consumers. We've got, we want better coordinated care. We have some demographic issues. We have some helpful stuff in terms of information management and technology, except that we got to figure out how to harness that. And then we have cost pressures and political and environmental pressures, particularly through Medicare and Medicaid. They're basically saying that we have to slow the rate of spending, and the only way they're going to do that is actually cut the legs out of fee-for-service. On the flip side of that, how many organizations right now are compressed by a case mix that's eroding and actually by cost pressures either within their market or they may be suffering some payer-induced reduction in their rates. Organizationally, there's a lot of people who are fearful and frozen at this point. Obviously, in any organization, there's internal politics and other structural barriers to getting it done. And so it's very rare you can walk into the CEO's office and say, hey, we need to do this. So you're frequently needing to lead more through influence and through coalitions of stakeholders within your organizations. So we'll go to the next slide. So we visited this earlier in the presentation, and when you can knit and have the community health needs assessment touch the very things you're trying to do in terms of cost efficiency and quality, that's going to resonate both with the current payment evolution toward value-based payment. You're trying to engage patients, which has everything to do with HCAHPS and CG caps and Press-Ganey scores, which are now translating to the bottom line. So when you can tell your organization that by addressing people's human needs and helping them by virtue of whatever you may be doing in the community, as well as naming, if you will, some of these bigger issues like mental health and housing and addressing food insecurity, that they could see that those things will make for a better patient. And a patient who feels better about themselves is actually going to be more compliant and is going to achieve their health goals, but they're probably also going to save the health system a lot of money. And those inefficiencies are things that are, quickly being driven out, if you will, of the system in a value-based setting. The other thing that we had talked about in this call is this sense of cross-sector collaboration. So I've made it a point to look for those opportunities to just have the 3-minute conversation or maybe even the 45-second elevator speech. So what's this community health needs assessment? And honing your message to say, yeah, this you should be interested in this because it's going to help you in your work. And then how do we stretch that out to the community level to have those same conversations with community-based leaders for folks from other health systems as well. Next slide, please. So if you think about it, your roles are those of that of an integrator. You're actually helping to sort of unite the medical care system, which is focused on disease, to the public health system, which is really focused on health. One is an individual enterprise where we're taking one patient at a time as they present for care. The other is really more of a population and public health where you're looking at hundreds of people who may have the same health issue, and then what are the policy and structural issues within communities that either help or hinder health from the perspective of what we'll call the built environment and social determinants. There's also the opportunity for community partnerships and individual engagement across that whole platform. Those are they can be very lively conversations, although people have to put their money where their mouth is. So setting up a community trust or leveraging the foundation for your health system to see if they might be willing to pony up on a per share basis to get into some other structure where they can share data with other healthcare organizations, with the health department, and with other government agencies who would be willing to share their information if they knew it was going to help the residents of that community. So it's got to be data-driven and evidence-based. We know that, but a lot of this is the hard work of, you're sort of being diplomats, if you will, for the present and the future. Next. So Debbie alluded to this earlier. I think it's good that you think about this as a continuous loop. This is a schematic that was provided by one of our cooperators, if you will, someone we're collaborating with WellSpan Health out in York, Pennsylvania. But they've sort of brought this in and made it a continuous annual cycle, both for strategic planning and then also for budgetary planning and then for execution. And so they have a performance management cycle at quarterly visits where they are pulling together their steering committee and guiding this. they have had the advantage of doing this long before the Affordable Care Act mandated it, because they felt that being aligned with the community needs was actually of strategic value in their market. And so they've been at this for a number of years and doing a very good job of it. Next. So here it's really been messaging and outreach and trying to essentially both educate and engage and get the commitment from the leaders who hold the keys to the resources. And so it's speaking their language, but also getting them to understand that we can tell our community benefit story, which is a good thing, and then if the carrot doesn't work, then we use the stick. Well, guess what? The IRS is watching. What would it look like if our community benefit went away? What if we lost our nonprofit status? That usually makes the CFO's eyes get really wide. Having a work group for project management and making sure that it can report up as high as you can get within your organization. We have a population health executive work group, and we also have a community relations committee of the Board of Trustees. And I have just been flat out up front saying that I would like the opportunity to come and visit those groups on a quarterly basis to give updates, because it puts this front and center and shines the light on it. You should feel bold in engaging whoever you report to say that you'd like that opportunity as well. We have multiple campuses in our network, and so we have found it helpful to have a leadership team composed with the operational leader as well as a clinical leader and usually a person or a service line leader to help guide those strategies at those campuses. So we'd like to have sort of a decentralized approach where tactics and strategy owners can actually work on and be empowered to do the work and then report their findings. And I would say that from the standpoint of that, we have another campus that has just come into our network where we are actually, for them, the community health needs assessment process last time around for them was something that they put a plan together, and as they reported, it sat on a shelf. And so making it real this time around, it is making them be very thoughtful about who they can engage and how they're going to use those resources. Next slide. So this is kind of where we are right now. We're still clarifying the process owners for our tactics. We've got just about all of them recruited. We are actually working with a metrics group that will actually define how we'll capture metrics. We've asked our process owners to look at what would mean success for them, so that impact piece that we're required to do this time around is something we've been very intentional about sharing with people who want to have a piece of this action, and saying, okay, well, how would you think something like this would be successful? Is it the number of people who show up at an event? Is it a clinical outcome? Is it a system improvement that's going to improve access for patients or maybe even patient safety? All those things are relevant metrics, and we want to do something that lets them just stretch a little bit from where they are and help them to think about it at the next level. We're also working on sort of that master project management system with our multiple tactics coming in. We wanted to have a dashboard for our coordinator so that she doesn't have to chase her tail getting the data from our various tactic owners, and that we would create the expectation that we put out there, the request for them to send in their data, and we would be able to then show it back to them, if you will, on a master dashboard that says how they're doing with their project, create a little peer pressure, how are they doing with their project relative to others who are invested in, and how the overall project is going. I think that may be it. Yep. So again, that's one health systems experience. I'm sure you all have some stories. I'd love to hear from a couple of people to see what about what I've just shared with you is very congruent with what you're doing. Maybe what's new, or what's really divergent. What are you doing that I could learn from?
Hi, this is Melissa from the Lehigh Valley Hospital, Hazleton. The one thing that I wanted to say is, through my experience so far in this work we're doing with the CHNA, is that there's a lot of work that our organization has been doing that we just haven't taken credit for, or has been done in silos in different areas, as to what Deb was saying about, multiple people may be working on a diabetic initiative. And so I think this is a really great project, or a really great program to really bring that all together, and also to take credit for the great work that our organizations do.
You know what? I agree completely. I tell people all the time, you have so much going on in your organization. You really should take credit for it. And, the other thing that I found is kind of as a byproduct of our work with hospitals on this is, especially those that are being challenged in tax cases, is that most hospitals are significantly underreporting their community benefit because it's just such an administrative burden to track stuff. And so they're not. So they're not keeping track of the dollars of community benefit. They're not reporting it. So, it's millions of dollars. We did an audit. We did an audit of one health system not too long ago where we estimated that they were underrepresenting 40% of they were missing it completely and not reporting for what we estimated to be 40% of their community benefit. Just based on talking to people about what they tracked and didn't. So you're absolutely right. So I'm glad to see those of you who responded to the poll thought that the information that we shared was very helpful. Other thoughts, reactions, comments, things you're struggling with individually that we might be able to share some insight or help you do some problem solving, or that others in the group could help with.
So Deb, this is Bob. You moved the slide before I had a chance to respond to the survey. So.
But you don't count, though.
Okay, but I'm hopeful it's been helpful. One of the things that I think would be helpful to us, I find these sessions, anytime you dial into a webinar, you hope to take maybe one or two nuggets away from you. But if folks would be willing, it would be nice to go around the room and just have folks weigh in on maybe one thing that they took away from this that will influence how they will behave moving forward within their own context. Anybody want to take a crack at that? One of the things that we are exploring in our region is potential partnerships with either local college or university, particularly those who either have a program in the social sciences or who have a data infrastructure that could be helpful for us. So we have some political science professors and social services based in some of our local colleges who are more than happy to help with your data acquisition for the Community Health Needs Report. But now that we're on the data tracking side, many of them are interested as well in teaching their students how to get engaged in this work, or in how to be methodologically rigorous with, what's realistic in terms of an output or an outcome. Anybody else doing that?
Well, in New Jersey, Rutgers has been involved, and it's often through the Schools of Public Health, which is what I would also say to folks in Pennsylvania, find out which of your schools have something, have a public health program, because those are definitely tied into all this and should have faculty and students available to assist. So I have another question, and maybe it's not appropriate for this forum, so you can just say that. But given the recent election and the uncertainty around the continuation of the Affordable Care Act, what does that mean for community benefit and these efforts going forward?
Do you want to take a shot at that, Bob? I have a couple of comments that I would make on it. From your perspective as a clinician, you have a read on that?
So most of my insight comes from having been the physician representative to our Board of Trustees over the last 5 years. And the feeling is the Affordable Care Act, by the time it was out of the gate, has set in motion a number of factors, of adjustment factors, if you will, that almost like the stock market, they're already built in. So from the perspective of payers, from the reality that government pay, because of our aging demographics, there will be more people in Medicare. With the expansion of Medicaid, which is not a genie that can be put back in the bottle, there will be more government pay as a percentage of our fee base, that, you know, which is, if you will, the fuel that makes a health system go. And so I think it's actually to the peril of any health system to ignore the demographics and the needs of the populations that they're serving. And so my own guess is, while this may not be as formal a process, it's still going to exist in a lot of organizations who are going to work at it. The degree to which they work at it and are intentional about publishing what they're doing may vary, but everybody's interested in outcomes. We now have the data firepower to do that in many organizations, and those outcomes are going to be meaningful to payers. And so I think that's what's going to drive the train.
And I would agree with that. And I want to just share something that I've heard A.J. Harper, who's the president of Healthcare Council of Western Pennsylvania, who speaks about this topic frequently. And his standard response whenever anybody would talk about the repeal of the Affordable Care Act is that both sides of the aisle agree with the CMS's train especially being on the track of value-based payments. And even if the Affordable Care Act as we know it gets repealed, probably the next day the legislation would be reintroduced to keep the components of it that everybody agrees with, because of the unsustainability of continuing rising health care costs and basically bankrupting Medicare. So those pieces of it are likely to continue to stay there. And as I would submit, those challenges to tax-exempt status. So the component of it that the CHNA deals with related to, moving toward population-based health care and, sort of being the validator of the nonprofit status to some degree, I would bet that those things would be, if they go away because of the Affordable Care Act repeal, would come back in pretty short order through some other legislation designed to keep the components that most people in Washington, regardless of political affiliation, believe to be necessary to keep, some semblance of fiscal sustainability.
Okay, thank you. That's very informative.
Other questions?
Elizabeth, you have an example within your own state where a county took one of the health systems to court over their nonprofit status.
Yes. It's a neighbor, not in Bergen County, but yes. Well, that
so
definitely
there's
put the spook in people.
Examples of where I think there are watchdog counties, school districts, lots of stakeholders that are going to be watching very closely at the behavior of nonprofit health systems and asking them to be accountable.
Absolutely. See, I think if they can really keep it, some form of it, then everyone will really take it seriously and feel like it's here to stay. And then I think that there'll be more formal systems put in place to make the data collection easier. But I think until it's really accepted that it's here to stay, it's a little wishy-washy. But I think somebody else had a question, so I don't want to cut them off. Somebody say something right before I... Oh, well, I heard somebody say I have a question.
This is Debbie again. I'm going to jump in and ask a question on behalf of other people that I heard ask it, because I know Bob has an answer to this that I think it's worth sharing. People ask me all the time, you know, is the IRS really going to police this stuff? And up until I heard Bob comment on his experience with the IRS, I wasn't sure they were going to. Would you mind sharing what you told me about the IRS really is paying attention to what hospitals are doing with their implementation strategies?
Yeah, so one of the awkward moments in my young career in community health at this network, we had an IRS agent come early in the summer and actually engaged our finance tax person and wanted to look over our community health needs assessment plans from 2012, 2013, so the previous cycle, and was asking why at that time we did not have a plan that was specific to each licensed hospital campus. That is actually in the letter of the law. We had done our community health needs assessment as a regional exercise, and because at that time we only had 2 licensed facilities, it was something that was overlooked. So we put together one plan for the region. The differences between the campuses were minimal, and yet at the same time, we got a little slap on the wrist. Fortunately, no fine. They just said, no, the expectation is you need to have a plan here for each of your campuses. So we expect you to do better.
Well, and that, to me, that experience is fascinating because I think under the draft guidelines, which was back in 2012, 2013, I think it was unclear at that point that that was the expectation. I think that the IRS absolutely in the final regulations clarified that. They make it abundantly clear that when you have to see each hospital's separate implementation strategy. But I didn't think that was the case a few years ago, but I just find it fascinating that they are in fact asking questions about that.
All right. Well, I think we're coming up toward the end of our time. Is there anything else that anyone would want to share in terms of something you took away from today's conversation, or how this might change or influence what you're going to do moving forward? Okay. Well, Debbie, I'm going to throw it back to you. I always like to give people the gift of time. I think we're just a couple of minutes ahead of schedule here.
Okay, and I just want to say on behalf of Dr. Motley and the Lehigh Valley Health Network and Strategy Solutions, I want to thank you for your participation. You've been a great group, and if you have any additional questions, our contact information, we'll be sending you the copy of the slide deck, and our contact information will be associated with that, and feel free to contact either of us with any questions or comments that you have after the fact. So have a great rest of the day, and we wish you the best as you move forward with working on your implementation strategies and evaluation process.
Okay, thank you.